Okay, good evening, everybody. My name's Alex O'Dare. I'm the Managing Director for Wound Care People. First and foremost, thank you very, very much for joining us this evening. Tonight's event is called Mastering Wound Cleansing and Debridement with Microworld. We're going to be introducing the 10th of a series of classes that we've been building over the last few years, which all have animations that are interactive, and each one is designed to allow users to learn in their own preferred way. We'll be introducing you to the latest Microworld class, which has been developed to help you learn about wound hygiene and debridement in a fun and animated way. All of the content is evidence-based and counts towards revalidation, and each completed class opens up other learning areas of the site. So please do check it out. We've got, as I said, other than tonight, we've got nine other classes that you can take part in, ranging from wound healing, egg state, infection, burns, and more. We're joined this evening by Paulo Ramos, who's joining us from Portugal. So Paulo is a wound care educator, a board member of the Portuguese Wound Care Association, as well as being a European Wound Management Association Council Member, and is the chair of the EWMA Education Committee. So hello, good evening, and welcome, Paulo. How are you?
Yeah, thank you so much. I'm good, and I'm very delighted to be here with all of you and to cooperate with Wound Care today, Microworld, and of course, a big thank you to you guys and to Monlika to support us in this class, and where we will focus about the cleansing and debridement and its absolutely pivotal role in terms of local approach in hard to heal, complex or chronic wounds. So thank you so much for having me today.
Excellent. Well, I've got just a tiny little bit of housekeeping to do before we start. So first and foremost, please do ask as many questions as you like. There's a live Q&A coming at the end. I'll be joining Paulo just to go through the questions that you put to us. I'd like to say a massive thank you to our partners over at Monlika. We wouldn't be able to do this without those. I'm fully aware, not just of the amount of work that goes into this evening, but actually the amount of work that has gone into making Microworld and the 10 modules that we've created so far a reality. I was having a look at this latest module earlier, Paulo, and playing some of the games, and I was slightly shocked at just how bad I was at them, and seeing how high some of the scores of some of the people around the world are. So please do check them out. We'll put links onto the screen for people to be able to get onto the Microworld online site later on. Certificates are available. This does count towards your revalidation if you're watching, and you'll be able to download those after the event. So without further ado, Paulo, I'm just going to play a quick video to introduce people to Microworld. We'll come back and then we'll let you get on with the presentation.
Thank you.
This wound is infected. As common as wound infection is, it doesn't make the battle any easier, and it's one that needs to be won to get the healing process back on track. And as you can see, it's got our team with their backs against the wall. And if Mr. X is this panicked, I'm not sure they'll find a way out of this jam. Wound healing isn't always under attack like this though. Our team has seen better times. Remember the phases of healing.
Hello, I think we're back. So a slight technical issue from my end then. Okay, so hopefully that explains a little bit more about Microworld. Paulo, over to you. I shall see you at the end of your presentation for the live Q&A. Good luck.
Yeah, thank you so much. And let's start our talk today. And as I focused previously, we will talk about the role of cleansing and debridement in terms of wound care, and how can we perform these techniques and take advantage of these techniques to better approach the chronic, hard to heal or complex wounds. So we know that the first thing that we must address is this learning objective. So I hope in the end of this session, we will be much more clarified about the definitions of cleansing and debridement and the difference between them. Of course, we must address why wounds need to be cleansed and debrided, and the importance, of course, of these two techniques in the whole process of taking care of a patient with a wound. So the holistic approach and holistic patient assessment is absolutely mandatory in this context, and this allows us to select and to reflect the decision-making process of perform a debridement and which technique use. We will approach and we will focus the different methods of debridement available at this moment and how to identify when debridement is not appropriate, and of course the referral or when should not be made, for example. So we try to address a lot of doubts that I think most of us as clinicians in our daily practice have. And the first thing that is important is we have a patient. The patient is in the certain context, and we must take and see the whole picture to provide the best care. And for that, we must take some data about the patient to see how it goes. And after gathering all that details, then we must take a decision. And the decision sometimes it's based and should be based in a comprehensive holistic wound assessment. And this is mandatory before we decide when to perform a debridement and which technique we should perform in terms of the first approach and in the follow-up of our patients. So this is very important. We will talk about cleansing debridement, but it's always based on the holistic assessment of our patient and the context where the patient are. And this is important again, and I highlight here some of the most important aspects of the holistic assessment. That is, the first and the base is the diagnosis of the wound type and that identification of underlying comorbidities, because there are some types of wounds that we should not debride in the first place. So, and that will be addressed later on. The social and the environment factors. So if the patient comes to me in my outpatient clinic where I work here in north of Portugal, it's different when I go to the home of the patient, and I have some limitations in the home of the patient that I don't have in my clinic. And sometimes the complex of the case is so complex that I must refer to the hospital setting where I work more closely. So it's important to address the patient family concerns and including the patient quality of life, of course, and addressing again the well-being and psychological factors involved. We must be aware that some techniques that we use in cleansing debridement could and provoke some discomfort or pain. So we need to be aware of that and prepare the patient and take some measures to avoid that, of course. And the practitioner skills are very important, our competence and resources in terms of our team. For example, am I the most prepared professionals to do it? Sometimes I am not, and I must refer my patients. So, and of course, be aware of the local guidelines and regulations. Another thing is the patient have a wound, and the wound could be classified in general if it is a healable wound, a maintenance wound, or non-healable or palliative wound. In all of these wounds, it's possible, and sometimes we need to apply techniques of cleansing and debridement to achieve our treatment goals. If it's healable, our main goal is to remove all the unviable tissue, all the infected tissue, all the contaminants, all dead cells of the wound, to allow the wound to progress to the healing. If we are facing a maintenance wound, our goal is quality of life, is to improve the status of the wound, to reduce bioburden, and again, we should implement some techniques of cleansing and debridement, but our goal is not to heal the wound, but is to avoid the wound deterioration, for example. So it's important to address all these goals. And if you are facing, if we are facing a palliative wound or non-healable wound, our goal is to stabilize the wound. Sometimes to control some symptoms like odor, we must or we should perform some cleansing and debridement techniques. But in this particular type of wound, be aware of our limitations and change some ideas with more experienced professionals if it's suitable for the patient to perform these techniques. Some definitions are mandatory in this kind of presentation. So wound cleansing is defined as the removal of surface contaminants, bacteria, remnants of previous dressings from the wound surface and its surrounding skin. So it's not an aggressive intervention on the wound. It's just removed by a fluid. When we put a fluid in the wound, it's like the physical passage of the fluid will remove these contaminants, that is not to attach it to the wound bed or surrounding skin. But it helps us a lot because it improves our ability to see the wound bed and the edges, allow us to remove organic and non-organic material and remove the excess of exudate. So this is different from debridement. Debridement is a more, how do I say, maybe a more aggressive intervention. With debridement, we remove dead tissue, remove infected tissue. With cleansing, we just remove what is in the surface of the wound or in the peri-wound, in the wound edges and peri-wound skin. Another thing that is sometimes is very often asked in our clinical practice is when what is the appropriate solution to cleanse the wound. This depends a lot of if we are talking about is this acute or chronic wound or hard-to-heal wound. If the wound is infective or in risk of infection, we prefer low cytotoxicity fluids to do it. Easy to use and available in our facilities, in our context. And of course, to see evidence, we seek for evidence-based products, of course, and the cost effectiveness. But sometimes we face so different types of wounds. You can see here a non-infective surgical site dehiscence and a traumatic traumatic wound in lower leg. And these are classified traditionally as acute wounds, but they are so different, and the cleansing solution should be different in this case. In another situation, we have two different leg ulcers. They are chronic wounds, but they have the wound bed and surrounding skin is completely different. Again, they are chronic wounds, but the need for cleansing and debridement is completely different in this situation. So maybe we should focus on what we have available, the context where we are, and of course how the wound bed is. So saying this, what is the wound debridement? Debridement is the removal of viable living or non-viable wound components, including necrotic tissue, slot, microorganism, biofilm with the extracellular polymeric substance, and foreign material. So with debridement, we go to remove all the unviable material that is in our wound that impedes the wound healing. And the primary goal is to reduce the presence of microbial and non-microbial components with less side effects. You can see here a sequence of pictures, and this is a patient of mine where in that time I just performed wound debridement with a curette, a dermal curette, 2 times a week, and just use a neutral dressing just to manage the wound exudate, and the wound progressed to heal very fast. So sometimes we need to take off from the wound what is impeding the wound healing, and that is what we need to just show the way to the completely healing to our patient with this kind of wounds. So unless it's contraindicated, debridement is a powerful weapon that allows us to, how do I say, showing the way, put the wound on tracks to faster healing. And why do wounds need to be debrided? I just mentioned some of that aspects as I am presenting this talk. But in this case, I will showing these two pictures of two olive trees. They are the same. And the olive tree was sick. At that time, the gardener just take off all the old branches, and 6 weeks later, the olive tree was completely new with new branches and new leaves, much more healthy. So it's what we achieve in our wounds when we are perform cleansing and debridement. We try to remove the old materials from the wound to allow the wound to reestablish it, the way for healing. So, and that's why it's so important to dominate these techniques and to apply these techniques in our clinical practice to achieve this goal. So it allows us to control the inflammation, to managing malodor, to improve quality, in the end, improve quality of life, and of course, allow us to see the completely wound bed, and in the end, we achieve more faster healing. And taking that point specific, this is not a very recent study, but highlights here the importance of debridement. And in this clinical study, it was found that 70.8% of the wounds healed with an average of 2 debridements per week. So, and in the end, the authors of the study found out that when we are facing chronic, complex, or hard to heal wounds, when we perform debridement in a more frequently, usually the wounds heal faster. So it's very interesting, this kind of studies, a very large study. It was analyzed more than 3,000 wounds, and very interesting. And you can, in the end, we have a list of reference. You can consult this study. It's free in the internet. So, and of course, the impact of wound debridement is very important. Here is a diabetic foot, the characteristic diabetic foot with hyperkeratosis, with a callus in the foot. And we here perform debridement to show the enclosed ulcer that was under this callus. And in this particular situation, it's very important to explain our patient that this could happen, because in the end, the patient could blame us for open a wound, but the wound is already there. We just not see him. So it's very important to involve the patient to explain that we will perform this technique. We will debride the hyperkeratosis and the callus, and there is a possibility that under that is a wound. One of the most important things that I think it's always related with debridement techniques, it's the decision-making process. So the professional have to collect certain data, to evaluate the environment, to know the comorbidities of our patient, to involve the patient and the caregiver, to see what resources we have available in our facilities, in our working facility. And another very important topic is to determine the right time to do it. For instance, in the case of infection, could be an urgent procedure. If not, it's not, we should, or we could wait. The knowledge of expertise in the local assessments is very important to involve more experienced people in this process and other elements of the team. Select the most adequate technique. It's very important too. So we have a lot of techniques for debridement, and sometimes we should not apply all at the same time, or we should apply one and complement the first one with others, as we will see later. And of course, reevaluate and consider other options and aims are not achievable. So reevaluate the process. So sometimes we think that we are facing a healable wound and it's a maintenance wound, for example. And the first question that I have to say to you, to present to you, is should all wounds be debrided? Of course, we have here two different wounds, and the answer, of course, is no. Sometimes we do not need to debride, because we have here, for example, This wound here is completely full of slotted tissue, here and here, this surgical site dehiscence. And here we have a pressure injury with a very healthy granulation tissue and with a ligament here. So these wounds don't need, this one doesn't need the debride here, but this one needs debridement because I have a lot of unviable tissue. So sometimes the wounds don't need all to be debrided, and we should continue to evaluate. The same question in another specific situation. It is mandatory to evaluate the vascular status of this kind of wounds in the foot and the calcaneus area, very important. And of course, these wounds, when we are facing ischemic limb or a stable dry scar in calcaneus area, we should not debride on the first place. Another traditional example is if we suspect of inflammatory ulcers, like in the first picture here, this one, let me take the pointer here, this one, we have a vasculitic ulcer, and this one we have a pyoderma gangrenosum. They are two inflammatory conditions. Unless the underlying cause is treated, we should not debride these kind of wounds in the first place, because when we debride, usually the inflammatory process increase and the wound enlarge a lot. So no, we should wait in this particular case and to treat the underlying cause. So most of the wounds we can safely debride, okay, but in specific cases we should wait. So dry gangrene is one of the aspects in case of mummified toes, for example. Lower limb wounds require revascularization, very often linked with gangrenes. And of course, the traditional case of a dry and stable necrosis, pressure injury on the heel, we should not debride that unless we will see some cases later on. So there is a right time to start debridement sometimes, yes, and the answer is straightforward here. Yes, there is. Sometimes we need to wait to see how the wound evolution, and then we start, for example, with autolytic or with mechanic and autolytic and mechanic debridement to see and to be more comfortable for the patient. And sometimes in this particular patient, ICU patient, that was my reality in the past, sometimes we have very unstable patients, and if is a dry scar, the dry scar function as a biological dressing. Please wait and see how the patient reacts, and because if we open a wound immediately, sometimes we open a door for systemic infection. So the traditional case of the calcaneus is here represented. In this particular case, I wait 5 months and 3 weeks to start to be more interventive in debridement, because this wound was at the time a dry scar, and then the dry scar evolved for non-dry with exudate and moving scar necrosis, and then I start sharp debridement with an adjuvant of autolytic debridement, and then the wound heal. And is that process, that decision-making, so important? That's why decision-making is so important. So we need to wait some time. And when we are facing very old and fragile patient in home care, like this old lady, 88 years old lady, with a very deep tissue injury in the trochanter area, I wait, and then I wait and see, and this was a heart-shaped pressure injury, very beautiful to see, but not so beautiful to treat. And we can see I wait, and after it developed an inflammatory process and the necrosis start to drain a lot, I finally decide to debride more actively, perform a sharp debridement, and then complement with dressings to help me in the autolytic debridement and in exudate control. So this is sometimes we need to wait, you need to see how the wound will evolve, and then we take the final decision to start debridement. And this is something that we must train and to discuss with our team. And in this particular situation, this patient had dry necrosis where he was in the ICU. Now he walks, and we can see here the necrosis is not stable anymore. The necrosis is we can see here unstable and with a lot of exudate at that time. So I take the decision to remove the outlayer part of this necrosis and treat with an autolytic dressing. And then we can see here with autolytic debridement, and we complement with sharp debridement with a curette. And then we achieve the completely heal of this calcaneo, and the patient continue walking and in the rehabilitation process. So of course, sometimes we should have some cautious, of course, and this kind of situations we must refer if we are not comfortable, or if we feel that we could cause more harm than to our patient. We cause harm to our patient. So wounds on the face, hands, feet, or genitalia, wounds located near major blood vessels, nerves, or tendons, implants of dialysis fistulas. It's very important to address this situation. Patient with clotting disorders, for example, on anticoagulant medication, because of the risk of bleeding if we perform, for example, sharp debridement, or if the patient have indication for sharp debridement. And patient, of course, with inflammatory conditions, as we mentioned previously, pyoderma is one of those, but we have vasculitis, ulcers, and others. Of course, we have a lot of different techniques, but usually we combine techniques in debridement. So it's in my perspective and in my reality, usually we combine mechanical, sharp, autolytic, or enzymatic debridement. Sometimes we start with, we want to remove the first layer of unviable tissue. For that, we use sharp debridement with a forceps and scalpel, or sometimes with a dermal curette. Then we use materials that have some autolytic properties or enzymatic properties to continue the process. And in the next visit to our patient, we continue to do some mechanical with, for example, debridement pads, or again, sharp with curette or scalpel, or scalpels and forceps. And then we complement and we use we combine these different techniques to achieve our goal. Of course, we should use different techniques depending on the complexity of the wound and based on our goal to the treatment. It's possible to heal, or it's a maintenance wound, or is a palliative wound. So it's very important to address that, and of course take the time to make your decision process. That is very important, I think, to do the better or to perform the better approach to our patients. So, and of course, they are more advanced debridement techniques, usually only do it in hospital settings, like hydrosurgical debridement, ultrasonic, the combine of negative pressure wound therapy with installation with specific foams that are open with large holes in the wound, and chemical debridement, that is the use of metasulfonic acid or chlorine compounds that help us to dissolve the unviable tissue, and then we perform, for example, mechanical or sharp debridement. So as we can see here, we need to know these different techniques to apply better in our clinical settings. And of course, the role of antiseptics is very important here, because when we are facing an infected wound, the first approach is not to putting immediately an antiseptic. We can use solutions or wound cleansing solution with antiseptic properties to prepare for wound debridement, if that is okay. But again, if we want that antiseptic act the antiseptic acts in a very effective way, we need to cleanse and debride to allow, for example, silver, iodine, or other antiseptics, honey, whatever you have available, to act and to perform the therapeutical action in the wound bed. Another thing is when we are facing biofilm wounds with biofilm, debridement will open the wall of removing the extrapolymeric membrane to allow the antiseptic to enter inside the biofilm and to kill the bacteria. Without debridement, the antiseptics are very poorly effective. So this is our message here is to perform these techniques before you use debridement. And of course, we have dressings that help us in this task of debridement, dressings that help us in the removing of unviable tissue, dressings that help us in a better control of exudate. It's very important when you have dressings that transfer exudate from the wound to the secondary dressing, and when the wounds are free from the excess of moisture, the wound it's much more clean. So this is important to see this interaction between the dressings and the wound bed, and the combination of the different dressings, the primary and the secondary dressing, how they interact, and that could help us in the better dressing selection, and that will help to maintain our wound clean. Now that I talk a lot about different approaches and I show you different strategies, let's put all the pieces together. So we have here an unstageable pressure injury on the sacral area, and we have here a street with a lot of dirt, and we cannot see the color of the stones, for example. So the first thing is, okay, let's try to remove more aggressively this. We determine that this is a healable wound. The patient have resources to heal this wound, and I need to see the color of the rock, so we must remove the dirt from the street. That's why we start a more aggressive technique with sharp debridement, with a forceps and a scalp, and I remove all the out layer of the necrotic tissue and expose as far as possible the viable tissue in the wound bed. Of course, I do not go too much into the wound edges, because that is viable tissue and could bleed, and I don't want to do that. I just want to remove the out layer. It's my goal with this debridement technique, and then I will decide to put, for example, an hydrogel with hypochlorous acid and sodium hypochlorite to continue the process of autolytic debridement. And then I will reevaluate if we are achieving our goal with this approach. So let's see the final result. The final result was this. So immediately after I debride, the wound was just like this, and the dirt of the floor, now we can see the color of our stone. So then as I said, I use a cleansing solution with hypochlorous acid and sodium hypochlorite, and then I put the gel of the same to allow us to continue the process. And we can see here that the wound, it's much better now, 2 days after. So I continue to put and perform the treatment twice a week. So I continue to put the hydrogel, and you can see here the dressing in the patient. Immediately after, remove the dressing. Then immediately after, I cleanse the wound and we can see this. There is a thin layer here. And 9 days after I perform the first approach, the wound is almost completely full cover of granulation tissue, and this revealed that was a stage 3 pressure injury. After we achieve the completely viable tissue in the wound bed, and the surrounding skin now it's in good condition and the edges start to epithelialize, I stop any kind of aggressive cleansing or debridement techniques. Just you can continue to cleanse with hypochlorous solution if you suspect that is a high probability of infection. This wound have high probability of infection. So, or you can just cleanse with saline. And then we decide to let the wound is stable, the exudate is controlled, no signs of infection. just perform a weekly treatment and continue the follow-up of this patient. And in the end, it was a full healable wound, and it completely heals after 127 days. So this is just a case, just an example, but I think it describes very well what we face in our clinical practice, in our settings, and what we must put on the what we should know to perform the right approach to these cases. In summary, I think wound cleansing and debridement are essential to remove debris, non-viable tissue, and microorganisms that accumulate on the surface of a chronic wound. But microorganisms are not only on the surface of the wound; they are inside the wound, and they are in the edges too. Because sometimes we must perform debridement of the edges too. But again, assessment is a key to ensure that the right debridement technique is selected. So the first slides where I talk about the holistic approach are very important, and I think it will underpin your decision. Of course, we must involve the patient, so patient collaboration is important to ensure that specific needs of the patient and the wound are met, including consent to the treatment. And if a patient are not, unfortunately, related to his disease, is not possible the patient to get involved, we have caregivers that help us and should then be involved too. Selection of the correct debridement method should be based on patient-centered outcomes rather than adherence to familiar techniques. So we should be aware that we must not, if I'm only comfortable with autolytic debridement, but the patient needs in the first approach of sharp debridement or mechanical debridement, I think we should, it's not only the technique that I'm familiar that should be taken into account, but what the patient needs at that time. And of course, the referral to appropriate provider should always be considered if you do not have the knowledge or skills, or you don't have enough materials, or you not have the materials available in your facility, for example, to perform the appropriate debridement method. After control local barriers, of course, allow the wound to heal undisturbed. So debridement is a powerful weapon, but we need to know how when we should stop. So as I show it, after 25 days, if my memory don't fails, I just stopped the debridement techniques because the wound was completely completely clean and without unviable tissue or tissue that could impair the healing. So I just stopped the cleansing debridement techniques, more aggressive debridement techniques, and allow the wound to progress to the healing. So this was what I need to I exposed to. I have to talk to you. So I'm very looking forward to our questions. And now I hand over to my colleague of this live Facebook Live. So thank you so much for your attention.
Great presentation. Lots of images on that presentation as well, which is fantastic. It's certainly the way that I like to learn by looking at things. So we've had lots of people watching tonight. I was just making a note of where some of them are from. We've had some people as far away as Mauritius and Australia watching. So there's some commitment. Thank you for joining us. Lots of questions come in, so we're going to do the Q&A first, and then I've got some information just to share with everyone regarding Microworld, how they can register, what they can expect. Excuse me. We've had quite a few questions. I'll just address something first, though. Quite a few people just asking whether they can access the presentation, whether they can go back and watch it. You can. After when we finish this evening, you'll be able to go onto our Wound Care Today Facebook page. The presentation will be available there. And from tomorrow, you'll be able to go onto the Wound Care Today website, and you'll be able to watch the video and actually get access to the slides on there as well. So do that. And certificates, a few people asking whether certain names can be added to certificates. We don't email you the certificates. The way it works, a link will be provided. you then fill in a form with whatever name you like, and then you download the certificate. So that'll be with you in just shortly at the end. So Paulo, if you're ready, I'm going to go straight on to the Q&A, and then we can get through this.
Let's see if I'm ready for the Q&A.
I think you're ready. I think you just absolutely smashed that presentation. I think you're. I think it was possibly because you were so excited to get to this live Q&A. So let's see. Okay, so the first question is, what is the best approach for debriding vasculitic wounds?
Okay, very good question. So the vasculitic wounds, usually the first thing is to perform the correct diagnosis. Are you sure that you are facing a vasculitic wounds? After we have the clear diagnostic, usually we need a biopsy, we need the involvement of a dermatologist, for example, in this. And after that, the second thing is the pain control, because usually that ulcers are very painful. And after we have the correct diagnostic and pain control, usually I try to perform, depending on the tissue that we have in the vasculitic ulcer. If we have, for example, more slotty tissue, usually I use, for example, solution with surfactants and combined with mechanical techniques like debridement pads. When it's too adherent, the tissue, and if the patient allow me, I try to do with a curette. Usually these wounds are very exudative in some way, and the exudate from the wound combined with some mechanical debridement techniques like debridement pads and sometimes using some autolytic gels, it's enough. But if the pain is not controlled, I advise to use autolytic debridement. Honey, it's not the best option, usually because it's too osmotic and sometimes the patient feels a little bit discomfort with honey-based dressings. But for example, gels with surfactants like octanidyne, like polyhexanate with betaine, for example. There are new that some gels with polyhexamer 180, I think, 144, I think is the right polyhexamer, that are very useful. So it depends what the colleague have to. So.
Okay, thank you very much. Next question. And I think you did touch on this a little bit. Is it okay to debride in people with diabetes? And what are the precautions needed?
Depending if we have diabetic foot, of course, if it is ischemic diabetic foot, we must be aware that if we don't have enough blood perfusion on the limb, on the foot, it's a high risk, and we should not debride until the patient consult a vascular surgeon, for example. Okay, or the patient must be referred for a level 3 diabetic foot unit, diabetic foot team. Usually they have vascular orthopedics, endocrinologists, podiatrics, and wound care nurse too. So if we are facing a neuropathic diabetic foot, when we are assured that we have good perfusion and we are facing, for example, callus or hyperpressure points, we should debride that. Because if we do not debride in the first place, the callus is a rigid area, and the patient walking over the callus area will provoke a subcutaneous hematoma, and then it will ulcerate. So if you are facing a neuropathic situation and a callus, you should debride, because this is a hyperpressure point and could ulcerate later on.
Okay, thank you very much. The third question I think is quite specific, and I'll ask it and just see whether you know the answer. But I think it's probably quite specific here to the UK. But we were talking earlier about the fact that your role in Portugal is you work in a community setting, so it's very similar to a community setting here within the NHS structure here in the UK. And the question is, can I ask, if you have a lower limb pathway, can I ask if you have a lower limb pathway where you refer to podiatry rather than tissue viability?
Okay, we have podiatrists working with us in community, and we have podiatrists that work in hospital setting. So with me, I have the opportunity to refer to a podiatrics that work in my facility in community care. So usually podiatrics here in Portugal treat non-ulcerative foot pathologies, not ulcerative. Usually when we have an ulcer in the foot, pediatrics need to be with a nurse, a wound care nurse or family nurse, wherever. But they are different strategies. But we in our community, if you have, for example, problem with the nails, problem with in diabetic foot deformations that need to be specific addressed by pediatrics, for example, we refer to our community care pediatrics. If the situation is much more complex, we refer to pediatrics to the hospital, and usually they work in 2 units, with orthopedic or in diabetic foot units, in these 2 contexts. So of course, I know that you in the UK, you have a very strong working pediatrics force. I think they work a lot, not only in diabetic foot, but in other situations. Here in Portugal, pediatrics they are not so available, if I can say so. In this way, it's much more.
Well, I think that I guess like you, I know of a few lower limb pathways, and I think it depends on where you are in the country, to be honest, and you need to look at whatever is being used local to where you work. Loads more questions. We'll try and get through as many as we can. The next one is around wound cleansing. So it says, is it best to use tap water or saline to cleanse a wound, or would you recommend specific cleansing solutions?
Yeah. I didn't address the different cleansing solutions because it's for that we need almost a specific mastery session. But usually, if I'm in a community care, and if the wound is not with contaminants or the non-infective wound, potable water or saline are similar, and the evidence say to us that we don't have problems using tap water or saline in same situations. For example, when I use a lot of potable water in the venous leg ulcer to clean the whole limb, and for example, after wash the leg of the patient go to just sit down, and I put, for example, when I suspect of infection, or the venous leg ulcer, for example, is a large one and with high risk of infection, I use solutions with antiseptics, with antiseptic properties to act only on the ulcer. Then I remove and perform the treatment. So we can combine techniques, but potable water and saline are, I think it's the fundamentals of wound cleansing. It's in the fundamentals of wound cleansing. If you are dealing with very hard to heal wounds with a lot of unavailable tissue, with high risk of infection, or to prepare the wound to debridement, or if the wound is infective, you should use cleansing solution with antiseptic properties in that. I think it's more or less my rationale in my daily practice and what is advised from in our facility, and based on the best available evidence at the moment.
Okay, thank you very much. Next question. If using a dressing to debride, how do I know if it's working, and how long should I carry on with it before trying something else if it isn't?
Okay. First of all, I think dressings alone, they don't have the ability of debride the wound. Dressings, I think, I see dressings as an ally to complement my work in the wound debridement. Okay, so as I show in the video, first I perform more aggressive techniques like sharp mechanical debridement. Then I use dressings to complement my first action and to maintain the debridement, usually the autolytic or enzymatic debridement for in the days after, and then I reevaluate. Using olive dressings to debride usually doesn't work. Okay, this is the first way. When you use in complement, usually after 2 weeks, you should see some improvements. And the improvement, it's not, for example, the wound to shrink or to reduce the size. Sometimes it's just, sometimes the wound increases the size because I remove all the unviable tissue, but the tissue type is completely different. You pass, for example, for a 100% wound cover with unviable tissue, for example, to 75% viable granulation tissue and 25, for example, unviable tissue. And you continue to perform the combined technique of mechanical, autolytic, or other. So just straightforward to your question, using olive dressings, I think it's not the best approach. Combined dressings with techniques or more interventive techniques of debridement, I think it's a better way. And usually after 2 weeks, you should see some kind of improvement in the wound.
Right, brilliant, thank you. Let's have a look. What have we got next? What is the best way to approach cleansing a wound and the surrounding skin? Would you recommend cleansing the wound first or the skin? So I think this sort of ties in quite nicely to what you were just talking around about whether you use an antiseptic or just saline. So do you do the surrounding skin and then the wound, or the other way around?
Yeah, usually, for example, I think it's more in this situation. I think let's put in context. If you are facing patient with leg ulcers, usually I cleanse all the leg and then I dedicate myself after to the wound. So I wash all the leg and then see the wound how it is and perform the wound cleansing in more detail or use more specific solutions to the wound. If you are dealing, for example, pressure injuries in the sacrum area, you go to a home of the patient and unfortunately the dressing is just came out and the wound is sometimes with urine or feces. I cleanse all the surrounding area and then dedicate again to the ulcer. If I'm dealing with an exudative diabetic foot, first I go and clean all the foot with soap and water, and then I go to the wound and perform the treatment. So usually it's in this way that I perform. So I don't know if I answered the question, but it always depends a lot. But in my way to approach, and I hopefully I pass that message. First, I see the whole picture, and then I go to the wound that is the small picture. So see global and act local. I think it's something like this. It's not the best phrase, but I think the message is here. Yeah.
It's a good phrase. New one on me. That's a pretty good phrase. And I guess there are a couple of others on here. There are a couple of other questions on here that are quite specific to dressing types. So, for example, somebody's talking about hydrogels. Would you choose a hydrogel for debridement versus sharp debridement? And I guess that you've talked around sort of obviously assessing things first.
Exactly. We can have two approaches. You can use an hydrogel to prepare the wound for sharp debridement or mechanical debridement. Usually, when possible, I prefer the opposite way. I start with sharp because let's think about when I remove the out layer or part of the unviable tissue, I will allow the hydrogel to act in a more effective way in the wound bed. That's my way of thinking. And in more than 20 years now of working, with different approaches in this, of course, another thing, I'm more comfortable performing sharp debridement. In the past, I was not too comfortable to do it. So it depends again in the way of your expertise, of your skills in using, for example, scalpel, forceps, curettes, and other, other surgical material to remove the unviable tissue. But in my perspective, usually when we start to easily remove, even if usually I don't remove the total area. I'm not a surgeon, so I remove what I can in the center of the wound. The patient usually don't have any pain at all. And then I put gels. It could be a simple hydrogel. It could be an enzymatic like collagenase. It could be, for example, products like with hypochlorous acid and sodium hypochlorite, because it have the two abilities. It helped me in autolytic debridement, and it prevents infection. That's very important too. And then I continue follow up, and I see, okay, the wound is respond in a good way. I continue to remove, if possible, parts of unavailable tissue and use the gels as a complement. That is my approach. The dressings are a complement of my intervention.
Okay, brilliant. I've written down see global, act local, by the way. I'm going to get some badges made up. So that's we'll definitely be stealing that, or using it, not stealing it. So we've got one final question. I'll give you a minute to answer this, and then we're going to just quickly recap on the session this evening. We've saved quite a nice technical one for last, which is when cleansing and or mechanically debriding, how vigorous should I be? Some guidance says not to damage new delicate tissue, while biofilm-based wound care recommends a vigorous approach to disrupt biofilm. What would you recommend?
Or it's a very complicated question to answer in like straightforward. Do it like this. No. Usually I'm as vigorous as possible according to the patient tolerance. It's very important because as I said, as we mentioned, I work in community care, so I don't have anesthesiology with me. I have GP. Sometimes we prescribe analgesic to the patient, but we don't have the ability of, for example, in the hospital to have anesthesiologists that give something to the patient to be calm and sedate, for example, to perform a debridement, more aggressive debridement. That is not possible in my context. So if the wound is with slot tissue and I try to be as more aggressive as possible, taking into account the patient tolerance. If the wound is like, for example, overgranulated, that is a sign of presence of biofilm. Sometimes I use products with surfactant properties and then just gentle try to remove with a debridement pad. Again, take into account the patient tolerance. So yes, the guideline says I need to be vigorous, but I need to balance that with the patient tolerance and with the pain of the patient. Another thing, biofilm is a very interesting way, and with these two topics, I will shut my mouth. But I will say to our audience, biofilm is important, but the wounds ultimately will heal with the presence of biofilm. We just need to maintain the biofilm lower as possible and lower in the way that host could handle with that level of biofilm presence, because we are not able to remove all the biofilm of our wounds, of our patients. We need just to lower down, and the host have the ability to heal with the presence of that bacteria. Another thing is the bacteria that are present on our wounds. We know in this moment that they are good bacteria that help us in the healing of our wounds, for example. We know, for example, that debridement have a extraordinary ability to allow for example, to remove, to promote the releasing of antimicrobial peptides to fight the bad bacteria. But for example, Staphylococcus epidermidis is a very good, Streptococcus epidermidis is very good to our wounds, for example. So we are not sterilizing wounds. We just are maintain the level of bioburden lower enough to the host to continue the healing phase. And again, bacteria are not all bad bacteria. They are very good bacteria, and we need to swap our way to thinking, and for example, thinking about modulation of wound microbiome. How can we modulate that to help to better healing, for example? Sorry, it's just to please study biofilms must start searching about wound microbiome too, because it will be the future. I think wound microbiome. How can we improve that?
I think that that's a whole separate there's a whole separate presentation, isn't it?
Yes.
I can see you getting quite passionate about that.
Yeah.
Well, listen, Paulo, thank you very much
thank you so much.
For joining us this evening. We really appreciate it, and it was a fantastic presentation. To everybody watching at home, please do visit Microworld. The website is www.mymicroworld.online. Like I said, you'll be able to pick up more information about this particular cleansing and debridement class, as well as various different games, and I hope you're better at them than I am. That's all I can say. But you'll see my name on there somewhere on a leaderboard, quite far down. So go on, see if you can beat me. Any of the other classes that you take part in on the Microworld website do count towards your revalidation, so you can pick up more CPD time for going on there. It's a really, really interesting and enjoyable way to learn. Thank you very much for your time, everybody, and thank you to all of my colleagues who are working this evening, and especially to our colleagues over at Mölnlycke for supporting this just really new and innovative way to learn. There should be a certificate now for all of you who've been asking for certificates. There should be a link to download your certificate online. You can have a look. You can go on there and download your certificate for this evening. And then some information for those of you that were asking. We have our annual wound care conference, which is called Wound Care Today. That takes place on the 12th and the 13th of March. Brand new venue this year. We're going to Telford International Centre. So please don't go, for those of you who have been before, please don't go to Milton Keynes because we won't be there. So it's the Telford International Centre. You'll be able to find that information online. And you'll be able to come. Actually, we'll have a stand there for Microworld, where you'll be able to come and meet some of the characters, meet some of my colleagues, sign up for the website while you're there and learn more, and also visit the Mölnlycke stand and see what products they've got, that some of which have been sort of discussed tonight around sort of wound cleansing and debridement. So we hope to catch up with some of you there. That's it, I think, Paulo, other than to say thank you again and good night. I look forward to seeing you in Barcelona in a few weeks' time, just to make the people at home jealous. It is a work trip. We're off to UMA, so we'll be there for work. Look forward to catching up with you in real life there. Good night.
You so much.
Thank you, everybody, for joining us. Goodbye.
Goodbye. Thank you.